The following is a paid program. WOR's airing of this program constitutes neither an endorsement of the products offered or the ideas expressed.
Here's Dr. Gil Lederman, New York's only Harvard-trained, triple-board certified radiation cancer doctor. If chemosurgery or radiation isn't working or isn't tolerated, when cancer and its pain and symptoms aren't getting better, seek a fresh second opinion at Radiosurgery New York's Urgent Cancer Consultants for innovative, custom-tailored cancer treatment. See our experts within one business day because we know your time and your life are precious. Our goal is proper diagnosis and effective, non-invasive outpatient treatment. Decades of leadership, first in New York with brain radiosurgery, first in America with body radiosurgery for cancers of the brain, body, and prostate, all custom-tailored for you. Call 212-CHOICES, 212-CHOICES for a prompt appointment and free booklet DVD. Super convenient, 38th and Broadway, with most insurances, Medicare, Medicaid accepted. You're next at Radiosurgery New York. Just call 212-CHOICES, 212-CHOICES.
Welcome, everybody. It's the Radiosurgery Show with Dr. Gil Lederman, MD, New York's only Harvard-trained, triple-board certified radiation oncologist who brings you the latest cancer treatment news, interviewing world-renowned cancer experts, delving to special cases, and, of course, answering your questions. I'm Rob Redstone, broadcasting from the WOR studios in the heart of New York City. And now, please welcome Dr. Lederman.
Hi, good evening. We hope you're A-OK and having a great weekend. Been great weather, and we're here tonight to talk to you like we do 5 times every weekend about trying to improve your health, live longer, live better, learn to think like doctors should think or may think, or try to understand why some people do things that we sometimes just can't understand, and we're going to be talking about all those topics tonight. We're live, so if you have questions, you're welcome to call us. Noah is running the studio tonight. The whole WOR studio is on his shoulders, and you can call and tell him hi while you're waiting to get on the air with us. The WOR studio number is 1-800-321-0710, 1-800-321-0710, so feel free to call if you have something important to add. I want to talk about a new study that just came out this week. It was published by ASCO. ASCO is the American Society of Clinical Oncology, which is the chemotherapy society, and there was a report by Charlotte Bath that came out that said that women with small breast cancers, cancers of a centimeter or less, lymph node negative, have excellent prognosis with no chemotherapy. The study looked at 4,100 women with T1 breast cancers and identified a lot of different types of cancers. Well, what do you think the survival rate? Now, women have, in general, for the local breast, either mastectomy, removing the breast, or lumpectomy and radiation, and we presented data on this program recently showing actually women have a higher success rate by keeping the breast and having radiation. So it seems like if you want to live, you can live. If you want to live with the breast, most likely you can live with your breast and have a high success rate. So what is a success rate? Well, the women who had who were followed 5-year distant-free relapse, so that means they were alive, distant-free survival, no spread of their cancer, for T1A breast cancers was 97% with no chemotherapy at 5 years. For T1B breast cancers, 95% success rate. So very high success rate for women with these breast cancers, T1A, T1B. These are often detected by the woman themselves or by mammograms. So excellent results. And I thought you'd like to just know that from small breast cancers, most likely it can be cured, most likely. There's never an always in medicine, but most likely 95, 97%, and most likely you can keep your breast and have a good quality of life. And speaking of that, we had a woman who came in this week with bilateral breast cancer. So she didn't have what Angelina Jolie had, which is BRCA, which is a genetic problem. This woman did not have that. She had two different kinds of breast cancer, one in the right breast measuring 0.5 centimeters, so about a quarter of an inch, and in the left breast she had invasive lobular cancer measuring about 2/3 of an inch. She had lumpectomy. She had great cosmetic results, so most people wouldn't even be able to tell that there was anything done on the breast. She wants to keep the breast, and that's, of course, a woman's prerogative. We support that fully. We support whatever the patient wants. We try to encourage the patient to understand all the risks, benefits, and options, learn what the options are. I believe she chose great treatment. Lumpectomy and radiation will give her a great chance of being cancer-free, keep her breast, and when you have the breast intact, you don't have the scars and prosthesis and other things that give a constant reminder of that surgery and that diagnosis. And this week we had a gentleman from New Jersey who came in with lung cancer. He was in another hospital, and they wanted to do all kinds of funny things. He was there for 2 weeks. They wanted to give whole brain radiation. Well, he had a lung cancer. He was coughing up blood, which is always worrisome, and especially if you've seen people that actually drowned in their own blood, it's terrible. So he was coughing up blood, and he had brain metastasis. He got discharged. His son came from Virginia, wanted him discharged. He got discharged and brought him to us immediately. We started treatment pinpointing the cancer in the lung and in the brain, and within 2 treatments, the hemoptysis means the blood when you cough. It's a medical term. Heme is Latin for blood. Optysis is when you cough. Hemoptysis. The hemoptysis stopped with 2 radiosurgery treatments. We only give 5, so unlike a lot of places that give 6 weeks of daily treatment or 8 weeks, no. We know that the biology is such that if you focus the beam on the cancer and you can dial up a higher dose, and a higher dose and fewer treatments actually is more effective and less side effects. So this man had radiosurgery to the lung and to the brain. And incidentally, when we staged him up, and we like to stage people up to know exactly where the cancer is, we found that he was in kidney failure, that his bladder wasn't working. He had been followed by kidney doctors for 6 years, but no one had done ultrasounds or evaluations of the bladder to see why his creatinine was 3.5. We did. We found 1,200 cc's of urine in the bladder. Now, normally when you feel like you have to urinate, for most of us, there's about 200 or 300 cc's. He, when I put a catheter in his bladder, had 1,200 cc's. Doesn't seem to be related to the cancer. This has been percolating for years. So a separate problem, but we try to take care of as much problem as we can at the same time, save the patient headaches, put a catheter in, drain the urine. He's now draining urine, and we're trying to determine why his bladder didn't work, as well as treat the lung primary and the brain metastasis, all non-invasively, all outpatient. He comes in, gets a treatment. Treatments last about 15 minutes. You come in, get a treatment, and go home, which is, I think, a heck of a lot better than being in the hospital and all the risks of being in the hospital. And we had another man who came in this week, very interesting. So he had cancer of the kidney several years ago. The doctors elsewhere removed the kidney, and he came to us because he was concerned about a pain in his penis. So imagine that. He had kidney cancer in the past. He now comes in with pain in the penis, and like I do with most patients, we staged him up, And guess what we found? Number one, a cancer in the good kidney. So the other doctors elsewhere removed his kidney. Now he's only got one kidney. Obviously, he wants to save his kidney and avoid surgery. So that's pretty easy for us. That's the work we do every day with radiosurgery, non-invasive treatment to hit kidney cancer and other cancers. Our success rate is very high. I've reported that elsewhere, and we've actually been invited to give a lecture at the world's largest radiology meeting, RSNA in Chicago, this autumn about our results on kidney cancer. That will be presented by Gil Lederman. But he has this pain in the penis, and the cancer in the kidney that we found, no one else had found it, doesn't explain the pain. So what did we do? Well, one of my colleagues looked inside the bladder, and guess what? There's a mass inside the bladder, and that mass is probably causing the pain in the penis. It's very close by. He's going to have a biopsy, and I'll report back to you if these two are related. It seems like they're not. It seems like they're two separate issues, and the bladder may be a cancer. Now remember, people who smoke have higher rates of kidney cancer and bladder cancer, so that may be a factor. But I'll report back to you on how he's doing with the kidney, radiosurgery for kidney cancer, and what's in the bladder causing this pain. So, interesting case. Back in Iowa, I don't know, we don't talk about it too much in New York, but in Iowa, when you cross a railroad tracks, when the train goes by, you don't just turn on your ignition and get going. On the crossings, they'll say 1, 2, or 3 tracks, because sometimes one train hides another train, right? So if you just get in your car and when the train passes by and start moving, you may get hit by a second train. Well, the same is true in cancer. Just because you find one, that doesn't mean that's only one. And in this case, if we stopped when we found the cancer in the opposite kidney, we would have missed what's in the bladder. So remember the trains in Iowa, on the crossing, it will say 1, 2, 3, however many tracks there are. If there's 1, look for 2. If there's 2, look for 3. Let's try to look as best we can to diagnose everyone who needs to be diagnosed, if that's you, and solve the symptoms. Usually cancer diagnosis and treatment should make sense. It should not be a puzzle. You should understand exactly what it is. And another patient I want to talk about is an Italian physician who's been a patient of mine for about 10 years. She has breast cancer. She has colon cancer. She has a meningioma in her head and bladder cancer. And she's been fighting a stage 4 colon cancer. It was diagnosed about 8 years ago and has spread to various sites. Now, first she had surgery. And at surgery, it was found that it was metastatic. She had surgery and workup because she had an elevated cancer marker, a CEA. So I often tell patients you should know what your cancer marker is. Like in prostate cancer, it should be a PSA. Colon cancer, CEA. Breast cancer, CA15-3. Pancreas cancer, CA19-9. Liver cancer, alpha-fetoprotein. So there's a lot of markers that help people find what they have and find if the treatment's working. So she found a colon cancer because of an abnormally high CEA. So she first tried chemotherapy and hated it. She nearly died from chemotherapy, and now she has stage 4 disease. And we know a lot of you are told if you have stage 4 disease, the cancer's in your blood, you need to take chemo. Well, no, not necessarily. That's one option. She doesn't want any more chemo. She has chosen just to go with radiosurgery. We stage her up and follow her every 3 months or so. If everything is A-OK, then she has a vacation. If there's a cancer, we can hit it with radiosurgery, whether it's in the lung or liver or lymph nodes. Those are the sites that we've treated in her over these many years. She works full-time. She's about 70 years old and carries on a good lifestyle, an active lifestyle. She just came back from a big trip with her family